Thank you, Sarah. Dr. Ann McKee is William Fairfield Warren Distinguished Professor of Neurology and Pathology at Boston University, Director of Neuropathology for the VA Boston, and Director of the BU Chronic Traumatic Encephalopathy Center. Her groundbreaking work on the long-term effects of repetitive head impacts, concussion, and blast injury in contact sports athletes and military veterans shifted scientific thought regarding head trauma. She demonstrated that repetitive, quote unquote, mild head trauma can provoke CTE, a devastating neurodegenerative disease. Dr. McKee published over 70% of the world's cases of CTE. She created and directs the Unite VABU-CLF Brain Bank, the world's largest repository of brains from individuals exposed to traumatic brain injuries, over 1,250 brains, and neuropathologically confirmed CTE, over 700. I will now turn it over to Dr. McKee. Thank you for being here.
Well, thank you. It's a pleasure to be here. And today I'm going to talk about CTE, obviously a subject very dear to my heart, and definitely the center of our work at the Boston University CTE Center and the VA in Boston for the last 13 years. Just having a little trouble with my slides. There we go. I have no relevant financial relationships to disclose. Your objectives, hopefully today you'll be, after listening, you'll be able to identify the key features of the pathognomonic lesion of CTE, be able to distinguish CTE from other age-related tauopathies, and list some common comorbidities of CTE. So, you know, all of this work really started with Harrison Martland and his publication in JAMA about a clinical syndrome that he said affected boxers who stayed in the ring too long. Even though he was a pathologist, a medical examiner himself, he described the clinical aspects of these boxers. He called it Prunstrunk. It went by various names over the last century. MacDonald Critchley introduced the term chronic traumatic encephalopathy, and that's the one that has stuck. We published our first paper in 2009. We looked at 3 cases, 2 boxers and 1 former NFL player with CTE. And because there had been so little written about CTE in decades, really 50 years, the last major report on CTE was in 1973 by Corsalis and colleagues, looking at 15 boxers. We wanted to review the world's literature on the neuropathological features of CTE. And that's what was in that original JNEN manuscript in 2009. These are our first 2 NFL players. Actually, my first cases were boxers. That's what started my interest. In 2008, we started a brain bank, and the first 2 former football players that we got in the bank were 2 45-year-olds, you know, 2 45-year-old former NFL linemen. And this was quite unusual for me. I'd never seen brain donors this young. 45 is, you know, early middle age for me. And both of them had played 9 years in the NFL. Both had developed subtle abnormalities that their wives noticed. Both had been married for a long time, and their wives noticed around the age of 40 some subtle changes in memory, ability to multitask, inattention. Tom McHale got hooked on painkillers, which was very unlike his former self. And then they both died at the age of 45 from accidental deaths. And this is just an image just to show that what was really striking about all these cases was the absence of beta amyloid and the striking florid tau pathology, which was quite unlike anything I'd ever seen, even though I'd been studying some of the primary tauopathies for quite some time. And that was really what piqued my interest. Back in 2008, we started a brain bank. It's been extraordinarily successful. At this point, the brains are coming in at least 2, sometimes 3, or many more a week. It's hard to keep up with. We've had some famous people visit the bank over the years. And just to give you this is an old graph. We did this back when we only had a little over 1,000 brain donors, but you can see just the exponential increase in the number of brain donors over the last 13 years, with this really substantial change in 2018 after the publication of our paper in JAMA describing 99% of former NFL players who donated their brain to the bank were diagnosed with CTE. You can see that we primarily get football players. We have over 700 at this point, although we're very interested in other exposure sources. Most of these are men. We're very interested in women, but their donation rate is lagging way behind. Just if you look at football players, you can see that even when we put this graph together the earlier part of the year, we have over 300 former NFL players. We're getting, believe it or not, about 3 in 10 NFL players who die. So about 30% of the NFL players who die, their brains end up in our bank. And then if you look at the timeline of CTE, this is when we wrote that JNEN paper. And that I do think really was part of this worldwide interest in CTE, a real change in the scientific interest, many more publications to follow. And now it's hundreds and hundreds of publications later. So what is CTE? It's a neurodegenerative disease. It's associated with exposure to repetitive head impacts. And most importantly, that is not just what we call concussions or the symptomatic hits to the head. It includes the asymptomatic subconcussive hits that players play right through, that people don't even realize might be injurious. But it includes these subconcussive injuries that accumulate over time, often over many, many years. CTE has now been neuropathologically diagnosed in all sorts of contact sports, football, rugby, ice hockey, soccer, wrestling, but it's also been described in individuals exposed to domestic violence, headbanging, and blast injuries. This is not a disease of the NFL, although NFL players do have this disease. But I don't think you should think of it as exclusively an NFL disease. We're seeing it in amateur athletes. We're seeing it in people in ordinary life who are exposed to multiple falls or multiple injuries. So even though we're learning a lot from the exposure of the very elite football players, this is the disease that reaches down really into society in general. Right now, we can only diagnose this disease after death. We do have criteria to make a possible and probable diagnosis of traumatic encephalopathy syndrome. We're getting closer and closer with biomarkers, including MRI and blood biomarkers and PET imaging for tau, but we're not there yet. It's all just research. Right now, we can only diagnose it with certainty with examination of the brain. So this is the quintessential CTE lesion. In green, this is aquaporin, or showing us the astrocytes at the depths of the sulcus, and then tau in red, circling around a small blood vessel. And that's exactly what CTE looks like. At the depths of the sulcus, in the cortex, there's a perivascular accumulation of tau in neurons, and that is the pathognomonic lesion of CTE. You'll notice it's at the depths of the sulcus. It's in the deeper cortical layers. We're not talking about changes in the superficial laminae. It's in the deep laminae, and it's very clearly neuronal. There may or may not be astrocytes within the lesion, but neurons with tau must be present. So the diagnostic features of CTE, just to reiterate, this cluster, this perivascular accumulation of tau in neurons around a small blood vessel, characteristically at the depths of the sulci. Can you see CTE lesions away from the depths of the sulci? Absolutely. It's just that there is a preference for the depths of the sulci, but we can see them on the bank and the crest of the gyroi. We can see them in the deep nuclei. We see them sometimes in the medial temporal lobe, amygdala, entorhinal cortex, even hippocampus. But the majority of these early lesions are in the cerebral cortex, preferentially the frontal, followed by the temporal and parietal lobe. Back in 2013, when we first described this pathology, we came up with a scheme for staging the severity of the pathology. We based it on Brock's scheme for staging Alzheimer's disease. We used large hemispheric 50 micron sections. And we defined stage 1 as 1 or 2 isolated lesions, these CTE lesions in the cortex. Stage 2 as more than 3 CTE lesions in the cortex affecting multiple lobes. And then, but nothing else of prominence away from the cortex. Stage 3 is quite different. That's when you start to see not only cortical involvement, these isolated epicenters, but you start to see distant involvement. You start to see a diffuse neurofibrillary degeneration of amygdala, entorhinal cortex, and hippocampus. And that we defined as stage 3. Stage 4, more widespread disease affecting broad swaths of cerebral cortex, medial temporal lobe, thalamus, deep nuclei, brainstem, as well as spinal cord. So a widespread tauopathy. These stages of CTE significantly correlate with the age at death and also the number of years of playing football. We use years of playing football as a proxy for the cumulative head impacts of an individual experiences. We don't have, obviously, we didn't have accelerometers in these individuals during life. So we use as a proxy for their exposure to head impact the number of years of playing football. So then in 2015, they convened a consensus panel of 7 neuropathologists to review 25 cases of various tauopathies. They were blinded to any clinical information and using the criteria that had been proposed in 2013, the panel was very successful in identifying CTE from the other tauopathies, even though some of these tauopathies were very unusual, like Parkinson's dementia complex of Guam. And they also stated that there was a pathognomonic lesion of CTE defined as an abnormal perivascular accumulation of tau in neurons, astrocytes, and cell processes at the depths of the cortical sulci and in an irregular pattern. Supportive features of CTE were that in the temporal lobe and areas like septal and insula, there can be a superficial arrangement of the neurofibrillary tangles. In the hippocampus, it's unlike Alzheimer's disease in that there's prominent involvement of CA2 and CA4, as well as CA1. Common other areas of involvement are the mammillary bodies, the hypothalamic nuclei, the nucleus accumbens, nucleus basalis of Meinert, as well as other brainstem structures. These are all supportive features, not in and of themselves diagnostic. And often the CTE lesions are associated with a form of RTAG as thorn-shaped astrocytes in the subpial region. If you find thorn-shaped astrocytes in the subpial region, it is not diagnostic of CTE, but it is a supportive feature if you see the pathognomonic lesion. And in addition, there were also the neurites, especially in early CTE, tend to take on a dot-like appearance as opposed to the thread-like appearance in Alzheimer's disease. So then we revisited these criteria in the second consensus conference. This time, 8 neuropathologists evaluated 25 cases of tauopathies of all ages, again, blinded to all clinical and demographic information. And the upshot of this second consensus was that the panel was able to identify CTE easily. They confirmed the robustness of the original criteria. They did make the clarification that the pathognomonic lesion must include tau in neurons and neurites to distinguish CTE from RTAG. There have been a few publications where they look at tau in astrocytes, perivascular tau in astrocytes, and it's diagnosed as CTE. This consensus panel ruled that purely astrocytic perivascular tau represents RTAG and does not meet criteria for the diagnosis of CTE. And then another important upshot of this meeting was that a single lesion, a single pathognomonic lesion was sufficient to diagnose the disease. We also looked at staging. However, it was inconsistent. I will say that we only had a limited number of paraffin slides and that the staging scheme depended on hemispheric slides and a large number of them. So when we tried to adopt it to a limited number of paraffin slides, it was not successful. So the panel came up with an algorithm on how to stage or evaluate the severity of CTE if you only have a limited number of sections. And then they divided the 4 stages into 2, low and high. And they looked at features. So let me just go through it first of all. If you see a pathognomonic lesion, that is diagnostic of CTE. If you have a high clinical suspicion of CTE and you don't find a pathognomonic lesion, this panel recommended resampling bilaterally, getting 4 to 8 cortical sulci and ensuring that you had the depths of the sulcus in the block to see if there truly was or was not a CTE lesion. If again you come up negative, it's non-diagnostic. If you do have that pathognomonic lesion, look for other features that might increase the severity. Are neurofibrillary tangles adjacent to the lesion? Are they in the bank and the crest of the gyrus? Are they found in the superficial cortical laminae, especially in the temporal cortex? Are there NFTs in the hippocampus, especially CA2 and CA4, the entorhinal cortex, the amygdala, the thalamus, the mammillary body, or the cerebellar dentate nucleus? If tangles are present in 5 or more of these regions, they suggested you call it high CTE. So some of the developments since we originally defined these criteria, we now know, I think it's been fairly well established, that the reason the tau is deposited in those regions of the brain, the depths of the sulci around blood vessels, is because of the dynamics of head injury. The physics of head injury find that the largest strain rate and strain is in the sulci compared to the gyri. This 3D computational modeling accurately predicts the location of the CTE lesions. And if you use finite element modeling of a sulcus and perivascular region during impact injury, again, you find the greatest mechanical deformation of the tissue at the depths of the sulci and around blood vessels. So the mechanics, the physics of the injury are the reason that tau is deposited in those regions in the brain. And we also know now that the tau in CTE by cryo-EM is different from that in Alzheimer's, another 3R, 4R tauopathy, and it's also different from the 4R tauopathies. It's very similar to Alzheimer's disease, but unlike Alzheimer's disease, it has an as yet unidentified hydrophobic molecule at one of its folds. And it's also very different from the 4R tauopathies and the 3R tauopathy. This is work of John Cherry from our lab. Important inflammation is a key feature of CTE. We see significant inflammation after repetitive head injury, even without CTE. Significantly increased inflammation in individuals exposed to repetitive head impacts without CTE, and then that inflammation continues to increase with the development of mild or severe CTE. We found that years of exposure are directly associated with the amount of inflammation. They're also directly related to tau pathology. the density of tau pathology, and there's a non-trauma related feedback loop where more trauma pathology leads to greater inflammation, and greater inflammation also drives more tau pathology. Looking at the staging scheme again, this is where we we wanted to see if the staging scheme was useful in characterizing these cases. So we looked at 366 different individuals neuropathologically diagnosed with CTE. We used semi-quantitative assessments of 88 pathology from 14 brain regions. We used digital slides and quantitative evaluation across 7 brain regions. We used age at death, dementia status, and years of football. And using all of these criteria, we found that the stages of CTE correlated with these parameters. So there was a significant increase in the semi-quantitative scales of tau. They significantly correlated with the CTE stage. The quantitative evaluations significantly correlated with CTE stage. We found that age at death also correlated with CTE stage. There are some exceptions. It's a progressive disease. There are exceptions with older individuals in their 70s, 80s, and 90s with low-grade CTE. Either this represents an indolent course or it represents individuals who develop CTE in the later years of their lives. But for the most part, it is a progressive, age-dependent progression. And this is the heat map showing the areas of the brain that are progressively more involved as the individual gets older at death. We also found that the stages of CTE are associated with dementia status for each stage. This is for each stage with an odds ratio of 1.6, and that it also correlated with years of football. So collaborating our previous work. We looked at a K-medoid cluster analysis and found that there were 5 optimal clusters of tau, 1 through 5. These clusters also correlated with the CTE stage, with the exception that clusters 4 and 5 correlated with stage 4 CTE. But you'll see there's a nice, the cluster 1 was frontal plus locus coeruleus, cluster 2, multiple areas of cortex plus locus coeruleus. So there was a very nice overlap between the cluster analysis and the staging. This is an important paper from John Cherry and John Crary, looking at the evolution of neuronal and glial tau isoforms in CTE. So they looked at 99 athletes with CTE. They had a wide range of age at death and a wide range of disease severity. And they looked at morphologic assessment and multiplex immunofluorescence to determine the ratios of 3 and 4R tau-containing neurons and astrocytes within the pathognomonic lesion. And they looked at various stages and ages at death. And what they showed is that in the early CTE lesion, which is a 3R and 4R pathology, the neuronal pathology predominates and 4R tau predominates. These are early stages, stage 1 and 2, and you can see that most of the cells involved in the pathognomonic lesions are neurons with a very small percentage of astrocytes. And that as the age increases, the age at death, there is a substantial increase in the number of astrocytes within the CTE lesion. This is most notable after age 60, when there is a large increase in astrocytic 4R tau. 3R tau was detected only in neurons, and with increasing stage of CTE, there's progressively more 3R tau. So just to summarize, CTE tau consists of 3 and 4R tau. P-tau neurons predominate in early CTE. 4R neuronal tau predominates in early CTE. Astrocytes only contain 4R tau. They also increase substantially after age 60. and they increased in association with age, not disease severity. And there's a shift from 4R towards 3R tau as the severity of CTE increases. This is just work done with some of my graduate students using single-cell RNA-seq, and we found that in the white matter of CTE, now looking under the frontal cortex at the white matter, that oligodendrocytes were reduced in CTE, and they were also had altered proportions of some subtypes compared to controls. The CTE-enriched oligodendrocytes had more transcripts relevant to iron metabolisms and cell stress, and we were also able to demonstrate excessive iron accumulation in the CTE tissue. We looked at astrocytes, and somewhat surprisingly, the number of astrocytes was indistinguishable between CTE and control samples, but transcripts associated with neuroinflammation were more elevated in the CTE astrocytes as opposed to controls. Also recent work, it's no longer in press, it's out. This is some seeding work that we did in collaboration with Mark Diamond's group. He took 27 cases of CTE and looked at tau seeding, and he was really only able to demonstrate tau seeding in stage 3 and 4 CTE. Of course, those are the stages where there's widespread tau pathology, whereas in the earliest stages, it's isolated in discrete foci. So it may be methodological, but it may be that this early disease is trauma related, whereas later disease shows progression due to seeding, maybe due to inflammation, maybe due to all sorts of different mechanisms. And then I wanted to point out this paper, I don't know how much time, because this is the dose response paper. We looked at 266 football players. People complain about the selection bias in a brain bank. There's no question there's selection bias in a brain bank with brain donors, much more likely to have their families contribute if they're concerned about the individual. So this is a paper that used a very sophisticated simulation and inverse probability weighting that accounted for all even extreme degrees of selection bias. And it found that duration of football play and CTE risk remain consistent despite all the selection bias that's present in the brain bank. In fact, what this paper showed that the risk of developing CTE increased 30% per year, and for every 2.6 years of football, the odds of developing CTE doubled. These are pretty, I think these are important numbers, that the risk is dependent on exposure. There were also inflection points where individuals who played less than 4.5 years were 10 times less likely to develop CTE than those who played longer. And if they played 14.5 years, they were 10 times more likely to develop CTE than someone who played less. And again, this wasn't just NFL play. This is football play at every level, youth, high school, college, as well as professional sport. I'm going to show you one case, Aaron Hernandez. You can look him up on Netflix. Here's his pathology. So his brain came into our brain bank. This is my colleague, Victor Alvarez, and myself looking at the brain. It was normal weight. It had an normal external appearance. Nothing remarkable about this brain on the outside. But when we did the coronal dissection, we could immediately see there was ventricular enlargement and a very thin fornix, thin gelatinous fornix. We saw perforations in the septum, which were extraordinary to me. I'd never seen septal perforations in a person only 27 years old at death. In fact, the next oldest player that I'd ever seen was a rugby player with moderate CTE who was in his 40s. And when we looked at his brain microscopically, we could see these very classic early CTE lesions, the perivascular accumulation in neurons with these prominent dot-like neurites in many parts of the brain, notably cerebral cortex, but again, as I mentioned, also in medial temporal lobe structures. And when we did those hemispheric sections, you can see just very substantial tau pathology affecting wide regions of his frontal lobe. We designated this as stage 3 because of the starting involvement of the entorhinal cortex and amygdala, but I think you'd agree it's an early stage 3. We did find inflammation within the pathognomonic lesion in his brain, looking at both IBA1, CD68, CD11C. We were able to find inflammatory microglia within the lesion. And again, we were able to demonstrate that the primary tau was 4R tau, it was primarily in neurons. Those dot-like structures that you see are primarily dendritic neurites. And then this is some early work with, it's very preliminary at this point. We haven't really fully gone through the data. This is unpublished. We're looking at early CTE, that is brain donors that die under the age of 34 and under. And you can see that of the 158 that we've had so far, about half, almost nearly exactly half, were diagnosed with CTE. Most of those stage 1, but 40% stage 2 and a few stage 3. Aaron Hernandez would be one of the stage 3. If you look, their mean age of those with CTE is about 27. Those without CTE, about 22, overall around 25. So likely those with CTE show are older at the time of death, but you can still see the sample is quite young. We don't have any females identified with CTE from sports exposure at this time. The overwhelming cause of death for both those with and without CTE was suicide, but coming close behind was accidental overdose and accidental injury. The primary sport played was predominantly football, but we had ice hockey players, we had soccer players, wrestlers, and other exposures. So it's not exclusively football. We do see other contact sports represented in this group. And then very notably, 2/3, about 64% of these individuals did not play high-level sport. They were either college, youth, or high school playing. So this is demonstrating the risk that we're starting to see over and over of playing amateur level sport and developing CTE. And again, remember this very young sample. Again, the features of CTE in this group, the heat map showing locus ceruleus, dorsolateral frontal, temporal, early involvement, and progressive increase with stage. We also found in this group that there are significantly more perivascular hemosiderin-laden macrophages in the white matter in this group. And that was true both in the frontal and temporal cortex. We did not find these subpeel thorn-shaped astrocytes in everyone. In fact, we only found about 20% of the athletes with CTE had these subpeel TSA. So these subpeel TSA, we do think are most likely a function of trauma, but they don't appear in these very young individuals. In fact, only about 20% of these young subjects had subpeel TSA. Again, these are not diagnostic for CTE. It's a supportive feature, and it remains to be determined whether or not they're related to trauma. That's something that has not been shown. So, but what these results do show is CTE is a primary tauopathy. None of these young subjects with or without CTE had any immunopositivity for beta amyloid. There were no plaques, there was no CAA. We had one subject with a Lewy body in the medulla. It was a 27-year-old with stage 2 CTE, but that was the only subject out of the 148 with a Lewy body. We did have 9 with TDP43 positivity, mostly as neurites. 3 of those 9 were diagnosed with motor neuron disease. So then I was just going to present a few cases, if I have time, and just see what you think of them. I just picked these out fairly randomly just to give you an idea of what what we see really every week at the CTE Center. So here's a case. I'm going to give it to you cold with no demographic or clinical information. Brain weight, 1374. Obviously, the whole thing's been fixed. No clear abnormalities looking at it externally. There it is from the dorsal aspect. From the side view, there's some nice cutting artifact, but other than that, nothing much. Looking at the brain coronally, again, it looks like a fairly good brain. White matter, gray matter, clearly defined, translucent. We see at this level, we're starting to see a little ventricular enlargement, frontal enlargement of the frontal horns, and a cavum septum. But other than that, no real abnormalities here. Maybe a little beginning enlargement of the third, but these are very mild and not clear. Hippocampus, amygdala look good. This is just looking at them more at a higher resolution. You can see the mammillary bodies look good. And as we go back, the brain looks to be in good shape. So no clear abnormalities grossly. But when we look with AT8 stain at the superior frontal region, you can see these beautiful perivascular clusters at the depths of the sulcus. I marked the depths of the sulcus here. There were no subpial TSA in this case. Again, the beautiful neuronal involvement with tau, the dot-like appearance surrounding the vessel, which appears longitudinally. We saw these throughout, inferior parietal. Here it is at a higher magnification. Some of these were apparent on Bielszewski stain, although clearly they're not as obvious. But if you look carefully at the depths of the sulci, you can see some of these lesions using silver stain. Inferior temporal cortex, again, the small blood vessel, the perivascular cluster, Rolandic. So quite a few lesions in this young man. Some early amygdala involvement, not a pathognomonic lesion, just a diffuse neurofibrillary pathology, involvement of the locus coeruleus and substantia nigra. No other changes to speak of. So what is the diagnosis here? Obviously, I think you're going to say CTE. The question is what stage? And I can't hear any of you, but so I'm going to go right ahead and say that it's, yes, this is stage 2. Mild frontal atrophy, mild cavum septum pellucidum. He's got multiple perivascular lesions affecting multiple lobes of the cortex. He's got some moderate neurofibrillary degeneration in locus coeruleus and some mild changes in the substantia nigra and amygdala. So pretty classic case of stage 2 CTE. This is a 31-year-old. He did play for a couple of years in the NFL and in the Arena Football League. He had a lot of problems beginning at age 24, 25. He was even diagnosed as bipolar and schizophrenic with delusions and hallucinations. He died from a motor vehicle accident, and that's how we got the brain. I'm going to show you a second case. Another brain weight, which is fairly unremarkable. An older individual, more pacification of the meninges. Again, aside from the removal artifact, some big problems with the removal, but nothing overwhelming on the external inspection. This is the side view. But when we look at the coronal dissection, again, you can see the frontal lobe and the enlargement of the frontal horns of the lateral ventricles, even though the cortex itself looks okay, but there is this ventricular enlargement. You can see the clear but small cavum septum. As we go more posteriorly, you get this concave appearance of the third ventricle, maybe some thinning of the anterior thalamus. Again, the enlargement of the ventricles, the atrophy, the thinning of the fornix. But those are the only changes. The medial temporal lobes look good. I think everything else looks good. And then this is the pathology. So obviously the microscopic pathology is sometimes much more severe than you'd expect from the external appearance. This superior frontal cortex, these are obviously a mat-like meshwork of these perivascular lesions concentrated at the depths of the sulci, but you can see clearly neurofibrillary involvement up the bank of the sulcus. This is looking at it with higher power. You can see this real perivascular clustering of the pathology. There's more astrocytes within the pathology. I think a lot of this astrocytic pathology is hard to classify. Some of it's thorn-shaped subpial astrocytes. Some of it is granular fuzzy astrocytes, but then a lot of this pathology is perhaps unclassifiable or remains to be determined. Here you can see it in another area of cortex, this very strong deposition at the depths of the sulci. Again, some astrocytic, some neuronal, inferior frontal. This is not a difficult diagnosis to make. Here we have the hippocampus, and now you see profound involvement of the hippocampus with a pretangle pathology, very extensive pretangle pathology and dendritic dystrophy in CA4. It's very prominent in this case. You can also see it in CA3 and CA2. CA1, you start to see some plaques, and indeed there was beta amyloid in this case, all stage 4 with maybe some sparse neuritic plaques. This is seen on Bielszowski, where you can see some neuritic plaques as well as tangles. Amygdala, perivascular lesion in the amygdala, the dot-like neurites. Some astrocytic inclusions, some appearing more neuronal. Involvement, I'm not going to show you all the different parts of the brain. Here, involvement of the nigra, very typical. Again, locus coeruleus, very severe. So this is the amyloid pathology. You can see a number of diffuse plaques, a few sparse neuritic plaques, and there was TDP-43 pathology, frontal cortex, amygdala, and hippocampus. So what is the diagnosis? Again, I think you're going to say that this is CTE. What I'm really going for is the severity, and this case looks very different than the last case, I think. Even the pathognomonic lesions look more evolved, more astrocytic, they're confluent, they're larger. So this is a stage 3 disease. Again, fairly mild atrophy, a bit more widespread. He did have the cavum. He had multiple pathognomonic lesions. He had widespread tau in the bank and crest of the cortex. He had dense involvement of the hippocampus. I didn't show you, but he had very dense involvement of entorhinal cortex. He did not, the reason I didn't go up to 4 in this case was he did not have prominent neuronal loss in the cortex or in the hippocampus. And there wasn't involvement of areas like basis, pontus, or dentate, areas that we do see involved in stage 4. So I thought this was high stage 3, but it was stage 3 disease. And again, his official diagnoses were stage 3 CTE. He does have Alzheimer's disease neuropathologic change. It fulfills NIA reg and of intermediate likelihood. But to me, the tau pathology was overwhelmingly CTE, with the exception of CA1 hippocampus. So I think it fulfills the criteria for AD neuropathologic change, but I do not think that it's a primary diagnosis. I think the primary diagnosis is CTE. And as many of our high stage CTE have, he also had late. He had white matter loss as well as small vessel disease. So this was a 63-year-old who played again in the NFL as well as the USFL. His symptoms began in his 50s when he got an increasingly short fuse. He lost interest in his hobby. He had trouble sleeping, more depression, more mood lability. He started having memory problems in his 60s and mild cognitive impairment. He became childlike, immature. He was more isolated. And he died by suicide. So then I'll get to case 3, and this is the case that I provided slides digitally. I gave you the whole case. I didn't give you a key sheet, so you may be completely confused about what I gave you. But I'm just going to go through a couple of slides from this case. I'm sure you haven't had a chance to review it, but this is another one of our brain donors. This is obviously a fresh brain that came in. Brain weight was about 1,092 grams. So this is a brain that's very, very atrophic. You can see that the frontal lobe is much more atrophic than parietal and temporal, but there's really substantial atrophy of all of those lobes. When you look at the undersurface, not so remarkable except for the small size. You cannot see the mammillary bodies, which is a feature of CTE, this sort of thinning of the hypothalamic floor, atrophy of the mammillary bodies. Side view showing, I think, more substantial frontal atrophy, which is quite extensive. And then this tremendous ventricular enlargement, lacune in the caudate. We can't tell you whether or not there was a cavum septum pellucidum because we did bisect the hemispheres, and that is lost when we do that. Just to show you the fixed side, but this tremendous thinning of the corpus callosum, especially posteriorly, and this marked ventricular enlargement. And then showing you a couple coronal sections, actually just one, the prominent frontal horns, the thinning of the corpus callosum, the dilation of the third ventricle, the atrophy of the anterior thalamus, this concave appearance to the third ventricle, pallor of the nigra, hippocampus rather full, surprisingly full for what the frontal cortex looks like, although there is dilatation of the temporal horn. I'm just going to show you a few examples of the pathology. This is Rolandic cortex showing subpial thorn-shaped astrocytes, a very gliotic appearance to the pathology. It is perivascular. It does contain a number of astrocytes. It is centered around blood vessels, but you can see that some of these morphologies are unclassifiable. Are they neuronal? Are they astrocytic? It becomes difficult to tell the difference. They don't, it's just a very unusual pathology. So this case, I'll just tell you, has chronic traumatic encephalopathy stage 4. I invite you to look at the slides of frontal and temporal cortex, which are very, very substantially involved. The hippocampus is relatively less involved, but he does fulfill criteria for stage 4 CTE. What was interesting about this case to me was that he had features of PSP. He has dense neurofibrillary tangles in motor nuclei like basis pontis, red nucleus, subthalamic nucleus, dentate nucleus, globus pallidus, inferiorlis, and spinal cord. And the astrocytic inclusions in this case to me were unclassifiable. So I invite you to look at that. He also had late, as many of our cases do. This was a 75-year-old. He played football for 28 years, including 12 years in the NFL. He started getting impaired at age 60 when he started having trouble driving, hesitations making turns. At age 70, he's showing slowed, effortful movements. He's anxious, he's falling. He starts to have asymmetry or poor functioning of the left side of his left side while walking. He tends to impulsively change his position, which triggers falls, and he has severe apraxia. By 73, he couldn't button a shirt or put a letter into an envelope. He has word finding difficulty, perseveration, poor insight. 75, he's got festination, occasional choking. He's got hypophonia, a bilateral tremor, severe apraxia, trouble with voluntary eye movements, increased axial and appendicular tone, frontal release signs, a wide-based unsteady gait with a stoop posture. He's got cognitive impairment, dementia, with relatively preserved, with a relatively preserved memory. His memory was relatively good considering his other cognitive impairment and death from aspiration pneumonia. So anyway, I invite you to
interrupt Dr. McKee. We just have about 10 minutes left.
Yeah, so I invite you to look at those slides and tell me what you think of the pathology. I'm interested to hear what you have to say. I want to thank all my collaborators, especially Tor Steen and Victor Alvarez and Russ Huber. Where's Tor? There's Tor. And all our RAs. It takes an army of RAs to do all this work. All my collaborators at BU and the VA. I want to thank the athletes, the families that donated these brains. This is a work that you can't stop because you see these young athletes cut down by this disease, and it makes you you just can't stop until we can figure this out. And I want to thank my funding sources, and I am ready for questions. I'm going to stop my share.
Thank you so much, Dr. McKee.
Yeah.
At this time, we're going to move on to the Q&A. So for the audience, you may submit questions using the chat box or also unmute to ask a question. Please use if you're using the chat box, make sure that the message goes to everyone so that everybody can see them. Otherwise, you can unmute using the microphone in the lower left corner. And then please remute again if you do. I'm starting to see things popping up in the chat, so I'm going to, would you like to read them or would you like me to?
I can read them.
Got
it. I'm going to respond. I'm sorry about the delay. I don't know anything about that between audio and visual, so apologies for that.
I haven't noticed it.
Okay. Why do some patients have very early onset symptoms and others take decades? It's a fabulous question. We don't understand it. We've got this young cohort that has symptoms. Of course, their symptoms are fairly nondescript. I mean, they're anxious, they're impulsive, they have a short fuse, they're angry, they may be depressed, they may be suicidal, but none of those are absolutely specific for CTE. It could be a mental health disorder, an adjustment reaction. So it can be very hard with these young patients to differentiate whether these symptoms actually indicate brain disease, brain injury versus something else. And really what you're faced with is having to follow these individuals and see longitudinally if they progress, because these are non-specific symptoms and it's hard to pinpoint what is going on. We have no way of detecting it using scans. And well, we're starting to see changes in MRI, but usually those are individuals that are older. So actually identifying these individuals when they're first starting to see the early changes of symptoms that we think are due to CTE, it's quite difficult diagnostically. But that's a good question. I don't know why some have delayed onset. And it's one of the conundrums that we're struggling with. So my next question is, can I comment on attempts to model CTE in animals? Well, so far, I think it's been extremely difficult to really model CTE, primarily because most of our animal models are rats and mice, lissencephalic animals who are very, very different than primates who stand up, who have, extremely convoluted cerebral hemispheres, a very complex brain. Even primate studies, which are unusual, the brain of a human is 10 times at least larger and much more complex. So part of it is I have not seen an animal model in primates. There are some pig models that have been used. I believe maybe Dan Pearl has a monkey model that he was using overseas. But we haven't been able to really model this disease, a progressive disease with perivascular pathology in animals. The rodent models tend to have aspects of the disease. They develop tau. They sometimes develop a progressive disease, but we're not seeing all the features that we think are characteristic of this disease. Then I got a question about correlating CTE and suicides. Well, we certainly see quite a lot of suicide in this work. I think that's been one of the strange features of this work is the high number of suicides that we get. I'm glad of that. Only in that we can offer some a repository for these families who are suffering. When you deal with a lot of families who are experiencing suicide, it is tragic. It blows them apart. They're filled with guilt and feeling like, what could I have done? And so I'm proud of the fact that our team takes these cases and really tries to give them answers. We don't always succeed. Obviously, not all of these people have CTE. We're seeing a high degree of CTE, but we can't absolutely connect it with suicide because suicide is so multifactorial. There's so many parts of it. It's certainly enriched in this group, but as far as pinpointing specific relationships, we haven't been able to. Have I ever seen CTE in a marathon runner? I have not, but I have not seen the brain of any marathon runners. We're really dependent in this work on the families to identify the problem and think of donating. Most of our cases just come from families reaching out. Our number is widely available online. You can reach our hotline, our 24/7 call line very easily, and families reach out after the death of people that we've never heard of. We get 90% of our cases that way. And another 5–10% from medical examiners. We get a few that are solicited, but that's becoming less and less. So if a family of a marathon runner thinks of it, we'd be delighted to look at it, but we have never had that opportunity at this point. Are there any population-based studies of CTE underway? I don't know of any population-based studies. I know there's studies of CTE in population or community cohorts. Neuropathologically, people are looking at CTE in the ACT study out in the University of Washington. We're looking at it in the Framingham study. And I think we're seeing very, very low instances of CTE in these community studies. But you have to remember that a lot of these people that are coming in for brain donation in these community studies have lived successfully to age 65 and older. And generally, if you're waiting for someone to be alive, successfully thinking clearly at 65, you're not going to see CTE because CTE is a disease of younger individuals. The onset is earlier, 50s, 60s, sometimes 40s, 30s, 20s. So if you're waiting till old age for them to, start to be taken into a brain bank, you're not going to see it. We really should be looking at CTE in medical examiner populations even more than we already have. We should be looking at in the brain banks that take brains for drug overdose, for accidental death, things that really seem to carry this population. Okay, I'm trying to read these.
I think that's all the time we have for questions today. I'm so sorry to interrupt, but thank you so much, Dr. McKee. Just a few closing announcements for everyone. Thank you again to everyone for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on the Path Learning Management System screen upon conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you have completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website in the next week. And thank you again to Dr. McKee for an excellent presentation. This concludes the session for today. Thank you, everyone.
Thank you.